Good afternoon, everybody. So, a lot has been talked about transepithelial PRK and about surface ablation already. So, I'll try not to repeat and I'll try to just talk about a few practical points on this. Transepithelial PRK, we had presented a few places and called it old dog with new tricks. So we all know that we were doing PRK at one time. It fell into disrepute because of the three main problems which have been discussed again and again today. And one was pain, second was haze, and the third was postoperative hyperopia. And with time, now with the coming up of transepithelial PRK, we have been able to almost get over all these problems. And along with this, as Dr. Nilesh said, there is a lot of peace of mind. And I would like to frankly share with you how I got started into transepithelial PRK. It was as Dr. Subhash had shown about the phaco nightmares. One day, my keratome got stuck and got stuck in two cases. Now, what's the option? So next day, I thought that let's try with transepithelial PRK because the company has been speaking so much about this transepithelial PRK, and let's do and see. And we know a few modifications we have learned from here and there. I think the Narayan Nethrale girls are also sitting here, so we had continuously seen how they modify and make pain management possible. So let's use those modifications and let's see how the results are. And to our utter surprise, whatever we had been expecting, that we will get calls in the evening of patients shouting that something has gone wrong with my eye. That didn't happen. As I said, we asked leading questions and that didn't you have any pain? They said no, some burning sensation. We were very, very happy. Then we thought probably there'll be a lot of haze, but at least few cases of haze. We didn't have any cases of haze over the next few months, so we were happy. And to top it all, now everywhere people were talking about bladeless surgery. So anytime the patient came to us, we used to tell them we will do bladeless, flapless, and touchless. Not just bladeless, flapless, touchless. And they would immediately opt for it, and they would opt for it at a higher price. So what could be better than that? And doing this, so that's the journey how it happened. And doing this today, it's like 95% of cases are transepithelial PRK, and sometimes we wonder, let's do one keratome because that keratome should not get rusted sitting there. So that's how we kept modifying our transepithelial PRK, and results kept getting better. And today we are very happy with the results. So the technology that I use is the Bausch & Lomb Teneo technology, and this has a truncated Gaussian beam profile, and the beam profile is very important whenever we are talking about transepithelial PRK because we need a very smooth bed, we need highly predictable ablation patterns, and we want minimal thermal effects. So all this has already been discussed as to why there is a resurgence of PRK, but I would say the most important thing for the resurgence is despite doing everything and doing a very good preoperative examination, we have found cases where everything was okay, yet they came up with corneal ectasia in the postoperative period at a later date. So there has to be something which has to be safer, and that safety option was transepithelial PRK. So since this has already been discussed, I will go over these slides. And most importantly, so many flap-related nightmares has been talked about. So we get over all these flap-related nightmares. As far as dry eye is concerned, since only the terminal nerve fibers are affected, hence these are the patients who have least amount of dry eye. So that becomes a very, very big advantage. We talk so much about vision, but we forget about dry eye because many of our patients keep complaining about dry eye. And this with Transepi PRK, we have found our patients, the complaints to be much, much less. So what exactly it is? It is removal of one step for removal of both corneal epithelium as well as stromal ablation. Just to show you a short video. That's the epithelial removal. You could see the green. That's the touchless part. So then the ablation, And the third part that you can see is very important, and that is the mid-peripheral zone ablation. Because I was talking about hyperopia. With PRK, we had patients of hyperopia, and that was because of the difference in the epithelial thickness that is there. So in PRK, we used to make it kind of a hyperopic profile when you were ablating. But in this technology, after you have done the ablation in the mid-peripheral area, there is a separate ablation which happens so that it becomes more like a prolate cornea. So this is the difference in between manual removal and transepithelial PRK. You get a very smooth bed as well as the smooth sides, which is what you want. And along with this, what we do is we give a slight offset to the towards a myopia. So the offset is around 0.25 for less than 3 diopters of power, and around 0.5 for more than 3 diopters. And this is how we have been able to circumvent the hyperopia that happens in the postoperative period. So now I don't remember any patient having any hyperopic changes in the postoperative period, which is so common with PRK. So epithelial thickness maps have already been talked about, so I'll again skip these, and coming straight away to pain management, which we have been discussing continuously. And apart from the what has already been told by Dr. Rakhi about this, this again we learned from Dr. Rohit and Dr. Pooja and Dr. Narayan Netrale how to prepare the Amplinac, in fact the AccuVeil soaked contact lenses. Now AccuVeil is not available, so we use Amplinac, where the contact lens case is first just cleaned with alcohol swab, and after that it is the Amplinac is injected inside it, and for 20 minutes we put it in the refrigerator before the procedure. And when we do the procedure, we just instead of a routine BCL, we will use this Amplinac soaked BCL. And this is data for around 122 cases where we found these were the pain scores. On day 1, pain score of 4. Day 2, pain score of, this is the average pain score. Pain score was 2. On day 3, it was 0, and overall it was 2. So this is much less. As I said, they don't even complain of pain. They just complain of little bit of burning sensation, and it's not a very severe complaint. So. So another thing that we were talking about was about the diluted proparacaine. Yes, we use the diluted proparacaine, which is diluted 20%, 80% is the lubricant and 20% is the proparacaine, and we use it only on the first day, and this is only for 3 to 4 times, and that is an additional benefit for that is additionally what benefits for decreasing the pain. If talking about the haze, these are the routine things which have been already discussed by Dr. Rakhi. So again, we skip these. And another thing that we add is cyclosporin in the postoperative period, and we use it for around 3 months, 3 to 6 months rather. And as of now, we are not seeing any cases of haze. And recently, we started using lifitegrast also, and we don't know how the results will be, but there have been studies which we have seen, which have been showing that it decreases corneal haze. And the big advantage over cyclosporin is that its action starts faster. So within 1 week, the action starts. At 2 weeks, the action is already started. So we don't have to wait for 3 months like cyclosporin. So finally, transepithelial PRK. We talked so much about it in this session. Thank you, Dr. Nilesh, for doing this session. And it's a procedure which is here to stay, and with wider applications. And yes, it is touchless, bladeless, and flapless. Thank you.
Thank you, Dr.